Okay. I will call to order the meeting of the Early Learning Council on February 22nd, and want to welcome everybody. Thank people for their flexibility in scheduling this around the weather that we've all been experiencing and some of us been enjoying. But appreciate the fact that we're obviously only meeting for 2 hours today, unlike our scheduled 7-hour meeting that we had planned on. And we will be rescheduling the early learning presenters for a later date, hopefully in early March. So we will try to pick up that sector sometime before our end of March council meeting. So watch for a doodle poll
It'll
that
go out right after this meeting ends,
Alyssa
yeah.
will be sending out. So today, this is our business meeting, and we obviously have a couple of key items, and one is the rules and the action item on our agenda, which is to adopt rules for regulating lead in water in childcare facilities. We've heard about this topic for a number of months now. We've had lots of different information, both from the public as well as from staff, and not just ELD staff, but importantly, the Oregon Health Authority staff, since it's really a health issue that we are going to be talking about. So I want to thank Pat and his staff for their support in helping us figure out how to move forward. We're going to start today with public testimony. Anybody who's here who wants to speak to anything on the agenda, and then we will go into the council deliberation. So I don't know if people have signed up, Alyssa, or...
Do you, because I don't know where Cass is. I'll grab that and then we need to do roll call.
Oh, thank you. Sorry, I can see who's here and I know who's on the phone, but we do need to do a roll call. Thanks, Alyssa. All right.
I'll go ahead and jump into roll call.
Yeah,
All right.
thank you.
Sue Miller,
Here?
Patrick Allen,
Here.
Martha Brooks,
Here.
Donalda Dodson,
Present.
Janet Doherty Smith is excused, Colt Gill is excused. Holly Marr, do we still have you on the phone?
Yeah, looking for her mute button.
A bit mute.
Back and check on Holly. Fair Rose Paxaresh is excused. Eva Ripito, are you still with us?
Yes, I'm here.
Great, thank you. Shauna Rodriguez, are you still on the phone?
Yes, I'm here.
Thank you. Donna Schnitker, are you still with us? Check back with Donna. Terry Talhofer is excused. Kali Thorne Ladd, do we have you yet on the phone?
Yes, I'm on the phone.
Thank you. Carmen Urbina, do we have you on the phone?
Yes, I'm here.
Great, thank you. Bobby Weber,
Here.
Miriam Calderon,
Here.
and Kim Fredland.
Here.
Great.
All right, thank you, Alyssa. Thank you, council members, for being on the phone. We understand it's hard to get here from afar, so we appreciate your being a part of this meeting. Let's go then to public testimony. We have 2 people who have signed up to speak, and we'll start with Celeste, my friend Swango. Is that close?
It's very close, yeah.
Welcome, Celeste. It's good to see you again.
Thanks so much. Chair Miller, members of the Early Learning Council, my name is Celeste Mayfrin Swango. I'm the Director of Environment Oregon, a statewide citizen-funded environmental advocacy organization. First, I just want to thank you for allowing me to speak today and for working to set rules around limiting childhood exposure to lead in drinking water. As you may remember, I was here at your meeting in January urging you to set strong health-based standards to protect children from the dangers of lead in drinking water and child care facilities, you know, the places where they go to learn and play every day. I am disappointed that the rules that you are voting on today set a regulatory standard of 15 parts per billion instead of a health-based standard of 1 part per billion, giving an illusion of safety for our kids. The science is clear that there is no safe level of lead, so it is unacceptable to allow any amount of lead in drinking water for our children. You know, it's disheartening to me that in this day and age, in the wealthiest country in the world, many of our children are regularly drinking water that has lead in it, which is a known potent neurotoxin. Even though we have effective, affordable ways to prevent it from happening, it simply does not make sense. A water filter that is certified to remove lead costs between $50 and $200. And from my perspective, that's a pretty small price to pay for giving our kids a healthy start in life. Your rules don't even mention filters as an option to mitigate lead, which I believe is a major oversight. And there's no mention of removing lead from the water delivery system itself, which is the most effective way to prevent exposure. Flushing water and using cold water are simply not enough. These rules also fail to make it clear to the child care providers that there is no safe level of lead. And to truly protect kids, you know, that they ought to mitigate at 1 part per billion, even though you're not requiring them to do that. You know, they're looking to you all for guidance on how to tackle this problem, but the guidance that you are giving them is misleading because there is no safe level of lead. So I have 2 main hopes coming out of this process. The first is that this isn't celebrated as a final achievement, but rather as a first step. And I also hope that the child care facilities that are in charge of taking care of Oregon's children will take it upon themselves to prevent lead exposure by installing filters that are certified to remove lead on all taps used for drinking and cooking, and then eventually removing lead service lines and lead-bearing faucets and fixtures from their water delivery systems. You know, I've heard people say that, you know, we just can't afford to take these steps, but from my perspective, we just can't afford not to. And our children's future is definitely worth the investment. So again, thank you so much for your time and for the opportunity to come and speak to you today.
Right. Thank you, Celeste. We appreciate you being here today. And thank you for your comments. Lawrence Rossini. Welcome back. Nice to see you again.
Chair Miller and members of the Early Learning Council, I'm Lawrence Rossini, and I'm back again. I didn't see the draft until yesterday and had these remarks prepared before I saw it. Rather than make a lot of adjustments, I will just say what I plan to say. It will underscore many of the things that Celeste said and that I said here before. I'm here as a private citizen and a retired consulting psychologist. Happy for the opportunity to come before you once again to speak to the rule that you're making to mitigate the level of lead in the drinking water of licensed and regulated child care facilities. If we're to produce kids who are ready to learn and to learn at their highest potential, we need to create environments that encourage their social, emotional, and cognitive development. There are positive things we can do to encourage them, like making sure the settings are places of physical and psychological safety. And there are negative things we can discourage, like the presence of everyday toxins that can damage a kid's brains and their developing central nervous systems. Lead is such a toxin which is known to impair those very attributes that we are chartered to foster, their emotional, social, and cognitive skills. I'm concerned that you may or are going to promulgate the 15 parts per billion standard for child care facilities, and so I want to reiterate what you've heard now many times, that any level of lead in drinking water puts kids at significant risk of cognitive and behavioral impairment, particularly young kids whose brains and nervous systems are in the early stages of development. And I read with horror that you may allow 15 parts per billion of water to be used to mix formulas for infants. To me, that is completely incomprehensible and a risk you should not take. Let's agree, no amount of lead, whether breathed in or ingested, is safe. Fumes, dust, paint, and water can all be carriers of lead, entering and accumulating in the body and never leaving. The absence of lead in water is a precondition for a child's full cognitive, social, emotional, and behavioral development. This is clearly affirmed by the EPA, by the pediatric, neurological, and psychological professions relying on years of research. And unless I misheard you, sir, at the meeting on January 25th, I believe that Director Allen and Public Health Administrator Orso also said the same thing, that no amount of lead in the water is safe, and you will correct me if I did mishear you. I apologize for that. I have great respect for your role in ensuring the Early Learning Division's mission to support all of Oregon's young children and families to learn and thrive. A rule requiring lead-free drinking water is a direct, singular, and effective way to do just that. If you do go ahead and pass the 15 ppb standard in the rule, I urge you to require the installation of certified lead filters on all taps. Easy thing to do. It's not going to break anybody's bank. They're economical and effective, and they're readily available. And they are visible evidence that a child care facility is serious about eliminating lead in its drinking water. You go in and you see it and you know. And it would be nice if you set another expectation that if in 2 or 3 years you come back to revisit this rule, you let them know that you may very well at that time require them to demonstrate through testing that the water throughout their facility is lead-free. That's my wish, and hopefully that's your goal, and I thank you for your consideration.
All right, thank you very much, Lawrence. Is there anybody else who wishes to speak? These are the only 2 people who have signed up. But is there anyone else wanting to provide testimony? If not, we will then close that part of our agenda and move on to discussion of the child care lead in water rules. And this is for final adoption, council members, so we need to make sure we've got our questions answered and are ready to move forward today.
Before we move, I just want to do one more quick check to see if we've got Donna Schnittker on the phone. I know she's having some technical difficulties. Donna, are you still with us?
I'm still with you.
Thank you. And then Holly, are you, I saw your camera, but can you just confirm you're on the phone for the record? We'll try her again.
She's mute. All right, we may hear from Holly. So I think leading us off will be Miriam. We'd love to invite our guests from the Oregon Health Authority to join us for this conversation. And on behalf of the council, I want to thank both of you again for helping us navigate this very important issue. We fully recognize this is really a health-focused issue, and so we know we need your input and expertise. And welcome Dawn Woods, who is our child care director. So glad to have you here too.
Great, wonderful.
Yes.
Thank you, Sue. So we are here to consider action on final rule on requiring licensed childcare facilities and license-exempt facilities that receive subsidy payments to conduct lead testing of water sources. Want to be clear that these rules do not apply to license-exempt providers not receiving public funding. I will give, I think, some highlights of what this rule does, consistent with the board action statement in your packets. And then I'm going to ask the Oregon Health Authority to specifically, I think, respond to some of the public comments today and that also have been received through the public comment period, specifically around the action level of 15 parts per billion standard, as well as provide more information on their recommendations provided to us around mitigation, et cetera. So first I'll note that the rule specifically does the following, requires...
Excuse me,
Yep.
On the phone, it's really, really hard to hear what Miriam is saying. Is there a chance that she could get closer or?
Sure, we're going to move this
I
mic.
apologize. I
No,
know
it's
it's
no
not-
problem. Okay. So the rule requires to test drinking water faucets and fixtures for lead and submit the results to the Office of Child Care by September 30th, 2018. If the test results are at or exceed 15 parts per billion, the facility must immediately prevent children from using or consuming the water by removing access to the faucet or purchasing bottled water. Within 60 days, submit a plan of action to the Office of Child Care to address the lead levels in the faucets or fixtures, testing at or above 15 parts per billion. The plan must be consistent with the U.S. EPA 3 Ts for reducing lead in water and drinking water in schools. Notify parents and guardians of the test results within 1 business day and post them in a prominent place in the facility, and retest the water after implementing the mitigation efforts. Facilities must test for lead in drinking water every 6 years, and the Office of Child Care will post the most recent results of these tests on its website so that this information is accessible to families and the public. And then regardless of the lead testing results, facilities must take preventative steps to reduce the likelihood of lead exposure, including flushing pipes before using for drinking water, cooking, or preparing infant formula, using only cold water from drinking water faucets and fixtures for preparing food, infant formula, drinking, or cooking. So that is, I think, a high-level overview and summary of what is in the rule. And this is, I think, as Sue noted, and I also want to acknowledge Director Allen and the guidance from the Oregon Health Authority, been an effort where we have worked very collaboratively and relied on the expertise of the Oregon Health Authority, both to inform how to adequately ensure safe drinking water for children in child care facilities, as well as provide guidance on the appropriate mitigation and corrective action efforts. And I would just underscore, particularly some of the comments that we heard this morning, that we do recognize this is very much the first step in this process to ensure safety for children with respect to drinking water in these facilities. We fully expect and recognize that we need to provide a large amount of support to our child care providers in understanding that there is no safe level of lead exposure for young children, support through the testing process to make sure that we get the kind of accurate results. We know that they will need appropriate supports around corrective action if needed, and the test results dictate that, as well as we look forward to being able to look at the kind of data that we get back to understand, I think, the extent of the challenge in child care facilities across our state, to be able to bring that information both to the Oregon Health Authority in our ongoing efforts to move towards ensuring safety of water in the facility. So this is very much, I think, very much the first step in understanding the extent of the problem and working with all of our partners to support providers for themselves, their families, and the children in their care, as we know that the majority of these home-based these providers are in private homes, and we have a great opportunity to get them the kind of information that they need, and then eventually, hopefully, the resources that they need to be able to mitigate. So with that, I'm going to ask Dawn if you have anything to add, or colleagues from the Oregon Health Authority, specifically to talk about your recommendations and the comments, or Pat, maybe before that, anything you
No, I'd
want?
like to make some comments later.
Okay, great. Thanks. Oh, okay, thanks.
For the record and for those individuals on the phone, my name is Andre Uso, and I'm the administrator for the Center for Health Protection within the Public Health Division. And my colleague today is Mr. Dave Emmy, and he's the manager for the Drinking Water Services program with the Oregon Health Authority. So I would like to just provide some basic statements on the action level, if that's okay. And then Dave and I will be able to answer some questions or clarify any statements for you if you'd like.
Thank you.
So I want to begin with there are no federal or state regulatory requirements as to lead levels in water at which an individual tap should be mitigated. Right now, the only thing that exists is this guidance from the Environmental Protection Agency. So OHA recommends an action level for lead found from water taps in schools and childcare facilities as at 15 parts per billion. This action level is more protective than EPA's guidance document, 3 Ts for reducing lead in drinking water in childcare facilities, which recommends an action level of 20 parts per billion. As has been stated several times today and in the past, OHA does recognize that there is no safe level of lead in blood, and OHA isn't indicating that it's okay to drink water with lead in it. The EPA recommendation of 20 parts per billion is not health-based. There really aren't any health-based standards that exist right now. The intent is to sample during the worst-case scenario, which would be the first draw from a tap. So this is water that's been sitting in the pipes within a facility probably for more than 8 hours. And in order to identify the sources of lead in the premise and plumbing and eliminate or reduce that exposure from those taps with high levels. The lead level in the first draw is not representative of what consumers drink throughout the day. The longer that water sits in a pipe and a faucet, the more lead can leach into the water. As water is routinely used throughout the day, lead levels are reduced. In Portland, flush samples were on average 93% lower in lead than on a first draw sample. Flushing taps until the water is cold is a key part of EPA's public education as a strategy to reduce risk and is included in these ELD requirements that you see before you today. Particularly when preparing baby formula or food or for drinking water, that's when the flushing is encouraged. Some other helpful facts is that the significant source of lead exposure is lead-based paint and associated with dust and soil. It is not water. When Portland Public Schools screened over 500 children for elevated blood levels after finding lead in drinking water taps in 2016, only 2 were found to have elevated blood lead levels, which was later attributed to a teapot. EPA estimates that drinking water can make up of 20% of a person's total exposure to lead. Neighboring states, California and Washington, have taken a similar approach of relying on EPA guidance or modifying it slightly. Washington's guidance is consistent with 3 T's guidance and cites a 20 parts per billion action level. California rules for testing of lead in schools use a 15 part per billion action level and uses a sampling protocol consistent with residential tap sampling required in the Safe Drinking Water Act, rather than referring to the 3 T's. So those are just some basic statements and facts about the action level and what it does and how it's protective of children's health. So if you have any specific questions, I'd be happy to answer those. And Dave here is more of an expert in the matter than I am, so we'd both be happy to clarify anything for you or address any questions that you may have.
Yeah, Bobby.
Thank you for sharing this information. What's unclear to me is if a faucet or water supply was at 15 points per billion and children drank it, would lead accumulate in their bodies?
Go ahead, Dave.
Well, it would, Dave Emmy for the record, it would represent an exposure, sure. But the whole point, I guess, to kind of underscore what Andre was saying, what our recommendation is based on, kind of the logic behind the Safe Drinking Water Act, that there are multiple barriers of protection. And so that's kind of the concept we have here. The first idea and line of defense is let's test samples. Let's sample premise plumbing and find sources of lead and remove exposure to those sources. That's really what that 15 parts per billion action level is about. It's not about trying to identify what is the ambient exposure that children are being exposed to in drinking water throughout the day. It's really a targeted effort to find and remove sources of lead in plumbing. So Removing that, removing those sources is a line of defense and reduces exposure. The second line of defense is just common practices that are incorporated in the regulations of routine flushing for 30 seconds or 2 minutes or until the water turns cold. And that sounds like a simple thing, but we have the data to demonstrate the effectiveness of that in reducing concentrations of lead by 90% or more, both in Portland Public Schools, with the City of Portland sampling from national studies, data I've looked at from Seattle Public Schools, all demonstrates the effectiveness of just that routine practice.
Okay. Donalda?
Mine is a follow-up to what you said. How many glasses of water would you have to drink to get that 15 per billion?
I'm not a toxicologist, and neither is Dave, and I'm not a physician, so we wouldn't know. But I think it's missing the point a little bit. So the purpose of the rule and the mitigation strategies is not to say that there's this acceptable level of lead that people can drink. That's not what we're saying at all, and that's not what the point of the rule is. The point is to be able to identify the source of exposure, mitigate that exposure, or cut the tap off. It's possible you can use filters, but there are some issues with using filters. So it's more identifying the exposure and then eliminating the exposure so children aren't consuming the water from that particular tap. So to say it's okay if you drink water with 10 parts per billion of lead or 5 parts per billion of lead would be, it's missing the point of the rule, and we're not saying that it's okay or that you can allow that small amount to accumulate throughout the course of the stay at the facility or not. That's just not the aim of the rule. And, we're not trying to say that drinking 4 parts per billion of lead is an okay thing. We're just saying that this is the action level for you to determine that this is the source of lead within the facility and that it needs to be cut off and mitigated. So I'm sorry I couldn't answer your question, but I hope that I've clarified a little bit about the point and the 3 T's and the mitigation strategies. And the testing and, the step in the testing, mitigation, and then.
I understand from that particular aspect, but what I'm thinking about is from the consumer aspect.
Yeah, there's no health-based standard that's been developed for lead exposure. There is talk that the EPA is working on it. The state of Oregon and other states in the United States don't have the resources to develop their own health-based standards. We do need that assistance from the federal government. So if there was an answer, I wouldn't know it.
Okay, Martha?
And Chair Miller, if there's somebody on the phone that I preempt, I'll wait a second, so if there's somebody that wants to.
Why don't you go ahead, and then
Okay.
we'll go to the
All right.
phone. Thank you,
Sounds good.
Martha.
So, Dave and Andre, I'm definitely listening to the individuals who are coming in and testifying that no lead is the optimum thing. Growing up in an environmental family, I kind of get those things. But I don't understand what mitigation fully means. Running the tap's great, but we've got a lot of old homes, especially in Portland, older areas in this state, Baker probably as well, who have been around for 100, 150 years and have these old pipes. And it just isn't making sense to me that you run the water and then we're good to go. And then I am concerned, especially about baby formula, because those are the brains that are developing the fastest at that particular stage. So, are we correct there? So what, besides running a tap, is mitigation? What recommendations can we have? What can we say? I'm having a real hard time connecting some dots here.
So the normal kind of sampling protocol or practice in the 3 T's guidance would require you to collect two samples. One would be the first draw sample, the water that's been sitting in a pipe overnight at least. And it's a small sample volume, so it's reflecting the water that's really in contact with, say, the faucet. And then you would run the water for a couple of minutes until it's cold, and then collect that sample as well. You'd collect those two samples. You'd analyze first the first draw sample, and if that came back high, then you would analyze the second sample. And what that would tell you is if the first sample was high, the second sample was low, you'd have some indication that it's probably the faucet, and it's the fixture that needs to be addressed. If it's a drinking fountain or a kitchen faucet, that's probably the source of lead. If the second sample comes back high, then you know it's probably, there's an issue further upstream in the plumbing. Maybe lead-based solder in the pipes, maybe we don't have lead service lines in Oregon, and the lead kind of goosenecks that had been in use have largely been removed. So we don't have that issue. So it's most likely plumbing and plumbing fixtures. So your options for mitigation, once you have that information in hand, are the first thing that you should do, and what the regulations would require, is discontinue use of that. Right? You're not going to serve water to children once you have that data in hand that says it's high in lead. But then beyond that, what the regulations would require is you prepare a mitigation plan, submit it to the agency, and what you're going to look at is various options. You could replace the fixture and then resample to verify that it's effective. You could use filters. You could install a filter. There are some issues with filters, and I think the biggest thing is just when we think about having a water filter within our own house, how diligent are we with replacing it every 3 months? We have some concerns about that, just being kind of creating a false sense of security in a way. But filters can be effective as long as it's the right filter, it's NSF certified to remove lead, and it's maintained and replaced routinely and in accordance with the manufacturer's instructions. Beyond that, of course, providing bottled water, is another option, or an immediate option if you're discontinuing use. But basically, that's kind of what we're looking at.
Could I ask a question just to clarify, because I think there might be some confusion around this, make sure I'm reading this correctly. As I read 9A, excuse me, on page 2, flushing the tap is what the rule says you do all the time, regardless of your test results. If the test result trips above 15, that's no longer sufficient, and you need to take other remediation action, and that ends up being, according to the rule, under 7B, I believe, sort of a case-by-case, here's the plan for how we're going to remediate in this case. We'll abandon the facility, we'll replace the faucet, all the things that David was just talking about in terms of that. I think people shouldn't be confused that a test result of 15 means, well, now we're just going to run the water. Have I got that right?
That's correct.
Okay, thank you.
That's correct. Yeah,
That's absolutely right. The routine daily practice of running the water just for a few minutes until it's cold should be practiced as, a matter of daily practice within any facility and within our own homes, really.
Dawn, just a quick question for you. I mean, we've known that for a long time, right? Are child care providers already aware of the fact they ought to be running the water till it gets cold?
I think there's been some technical assistance provided, but not real specifically. So I think getting it in rule will make it very clear of what the expectations are and the technical assistance that we provide afterwards.
Could I make a couple of comments, unless someone on the phone wants to
Yeah.
get in?
Anybody on the phone? Eva, Shauna, Donna, Kali, Carmen, have a question or a comment at this point? If not, we'll go to Pat. Yes, Eva.
This is more of a comment, and it's more, I think that for me, this is frustrating in a way that, I am looking at the
Eva, can you talk a little bit louder or get closer to a mic? People are having a little trouble hearing you.
I think for me that where I'm stuck on this, and I'm not stuck so much as frustrated. I think I'm frustrated because, like so many other pieces of our early learning system, this is another area where we would be able to do so much more and do so much better than what we are doing right now if we had better funding. I think that, I totally understand the concerns from our environmental partners and friends that we should eliminate exposure to lead completely, but then I also understand how, I'm getting, I don't know, I'm just flustered that we're in this position where we can't do the very best. And then even the cost of filters and replacing the filters is a burden on providers. And until we're able to fund that, it will be a cost burden on providers, especially family child care providers, that every penny is very carefully monitored. And so I guess just me, I always do, about how we need to fund the system in a much better way so that we can meet these health and safety standards that are so crucial.
This is Kali.
Yes.
I just want to echo everything that Eva just said. I agree. I think it's hard because I think the questions are the same questions that I would ask that have been asked today, but I think it is hard because we don't have the funding to do what we really want to do. And yeah, we're trying to do our best. I don't know. It's hard. So I resonate a lot with what Eva said.
Okay, thank you, Kali.
Then this is Carmen.
Okay, Carmen?
Can you hear me?
Yes, thank you.
And again, I don't want to sound redundant, but I also agree, and I'm shaking my head as I'm listening to the conversation and to the stats and just everything. And so to me, the essential question that comes to my mind is, do no harm. And in the policies that we know that they're not good enough. And I think that we need to be really transparent that this is not good enough and why. And make it very transparent to the communities as we're making these decisions, as we're trying to incorporate these policies around, health and safety for our students. And again, it is frustrating because we know the effects of lead. We have enough research to be able to understand that. And so in the now, as we are saying yay to what we have, which is the best that we can do, is it that we feel comfortable the best that we can do will do no harm. So that's what's coming forward for me right now. Thank you.
Thank you, Carmen.
I had a follow-up question.
So do
I.
Yeah, I'll get in the queue.
Okay, Pat's been.
No, look, go ahead.
You want them to
Yeah,
go
yeah,
first,
go ahead.
and then we'll come back to you, Pat? Okay, Martha, and then Bobby.
Thank you, Chair Miller. So I want to go back to you, Dave and Andre, what you said as far as if there's a problem, then they need to submit a plan. And my question at this point is, we have a lot of providers who probably don't know what kind of plan to submit. So is there anything or any proposal on how to help submit a plan that would mitigate any of the issues? How do we help our providers? And
That may be a Dawn question, because I'm sure you guys have talked about that.
okay,
And really what we're looking at is that our partners will help us kind of look at the 3 T's guidance and really create essentially kind of like a checklist or what that corrective action plan that really describes the steps that we need to take, so that we have a simple, easy to read, very relevant to whether it's a family child care or a center child care, so that we have those technical assistance documents. And it needs to be easily readable for our providers, as well as for our licensing specialists to really be out there providing the TA and walking them through the steps that they need to take. And so that will be developed once these rules are promulgated, so that we can have that really clear guidance for our providers.
If I just may build on Don, what Don said, and I think some of Dave's comments kind of gave you further information and context about this. So rather than really specifying in the rule or requiring purchase of filters, for example, the actions that we've taken, because I think the results also matter, I think, as Dave was explaining, around what is appropriate corrective action. And so again, this is really the beginning of understanding what among all of these facilities and providers and in these homes, we're knowing getting the kind of data and saying who among them are likely to have are demonstrating high levels of lead in water, and then being able to work where I think we'll be working really closely again with OHA to be able to give that kind of technical assistance to providers around corrective action. And I think we will have the data to inform, I think, the follow-up discussion. So we are going to have to, whether those are additional resources for providers to mitigate, we'll have an understanding of that, because we'll be able to look at data. We'll have, I think, hopefully, and I hope I'm not speaking out of turn here to colleagues at OHA, I think we'll also have the data to help us understand, the extent of the problem as we and the country move towards more of a health-based standard. So I think I'm sort of jumping in a side of Pat in the queue, but as I've understood this issue, it really is a first step to highlight those facilities where there is a concern. I hear the comments about sort of affordability and resource questions for providers, but I want to be clear, we are in this rule requiring them to mitigate, and so those resource issues or affordability are not at play here. There's not sort of an option, I think, as Pat said, flush your pipes if you're at or above 15 parts per billion. It's like you will mitigate, but we'll also have data and understanding if you're at 10 parts per billion or 5 parts per billion, and I think that will also help us continue to understand the needs of providers and the costs, right? If we have data to show this is a significant hardship, or a number of providers are affected in ways that are really costly to them, then I think that's important information that we have for moving forward. I also want to, since I sort of jumped out of turn, ask Dave and Andre if you could talk a little bit more about how we might know actually what children are ingesting, and what kinds of tests sort of exist for that. Because I think we're clear this is about an action level that is going to inform corrective action and mitigation and help give us the data. But, we know that, and I think as we've heard in the comments, there is a lot of concern and questions about how do I know what my child is actually ingesting, and I think just so that council members can also hear that, as we've discussed, because I think that's also information we can be providing our providers, right, as they get their test results back, right, and they look at what that data shows them.
Yeah, it's tough because, again, the first draw sample is going to represent the worst case scenario, the highest expected value that anyone would be exposed to during the day, and a running sample, that is a sample collected after you've run the tap for until it's cold, is going to be more representative of daily exposure. And you may not have that. If you have 15, above 15 and or even below it, you just have to put that number in context, I guess, is all I'm trying to say.
Mm-hmm.
But if I could respond a little bit to what I think you're getting at. Once this rule goes into, or whatever rule we adopt goes into effect, we'll begin to build up a base of data about results. And we'll have, wherever the threshold we ultimately set is, we'll have some body of providers that are just below that threshold, right? And I'm absolutely willing to have OHA work together with the council to come up with some kind of a research protocol or some kind of a data gathering system that would allow us to actually look at kids who are in those circumstances and have a base of data that we can draw from to be able to then ask the next question: is that level? Does that need to be actionable at a lower level, which is really what this is about. This is not about safe levels of lead. It's about the level at which we need to require people to take remediative action. And I think we'll then have data that we can work together on to be able to answer those questions.
Right.
Can I ask a question?
Yes.
This is Kelly. I'm still confused about what I heard people testifying on and what whoever was just speaking is saying. Is there any safe amount of lead? Like, it seems like there's discrepancy over that very critical piece, and I guess I don't understand why there's discrepancy.
Yeah, this is Pat Allen. I was talking earlier. I was quoted accurately earlier. No, there's no safe level of lead exposure, and that's not what this rule. This rule does not have the council saying that. And I think that's the thing that people need to be really clear about. What this rule is saying is, what's the level of lead exposure that is such that we need to require someone to take additional extra action to change out fixtures or alter piping or abandon faucets, or all those kinds of things that we've been talking about. The safe level of lead and the action level at which you have to remediate are two different things. The rule is about the second one. The rule is not about the first one. And I'll just go ahead and make the rest of my comments since I've got the floor. And as a regulator, that's actually, and in this case, we're a regulator. That's the balance that we need to figure out: is what of a variety of risks are we dealing with that we balance in a way to create a system that's most effective? Because we do have risks of people looking at this and a variety of other regulations, and at some point, kind of throwing up their hands and say, "Well, I'll just go underground." And there have been a couple of really high-profile underground horror stories in the news the last couple of days, of people who are trying to avoid the whole regulatory system. Now, I don't want to suggest that a $20 test by itself does that, but I think as we regulate, that's why we have an action level, and why that's different than a statement about what a safe level of lead is that balancing. I think I'd be happy with a shorter turnaround time in terms of retesting, but I understand the effort to work together with the rest of Department of Education on the standards for schools and have those harmonized. I understand that also harmonizes with State of Washington, and there are some values in that. Also, to the comments about sort of the rule should clearly tell people, what is a safe level of lead or not. I actually spent a fair amount of my career working on how to make business regulations work better, not by lowering standards, but by making them simpler, easier to understand. Rules are marvelous tools for lawyers to make a decision about whether or not you violated a rule. They're terrible as guidance to providers or businesses about how they should or shouldn't behave. And if anybody thinks that we should be relying on rule language as what we're going to give daycare providers to be able to read and figure out what they're supposed to do, they're nuts. We need to be able to have supplemental educational materials, things that are plain language, that are easy to understand, that can talk about topics beyond the rule as well, and talk about best practices, talk about how you should operate, talk about things like filters if that's appropriate, and you're able to really provide an educational body of material that serves a very different purpose than what rules do. Two more points and then I'll shut up. I do think that there is evolving science and standards around this, and that it's been said already, but it's worth saying again that we not only can but need to revisit this topic periodically and see if this action level continues to be appropriate, or if in fact the general consensus has changed further EPA regulations. And the last point I want to make, I think, is the most important, which is I'm comfortable with this rule as drafted, because this rule will reduce the exposure of kids in Oregon to lead as drafted. There are places out there now that are above the 15 parts per billion action level that will have to remediate and will reduce that lead from the environment. And so Oregon kids will be protected by this rule. As we revisit this and do more work with education and all those kinds of things, there's certainly more over time we can do, but I think I'm comfortable with this rule as it's drafted.
Okay. Thank you, Pat. Bobby.
So first, just a comment. It was really helpful, although I'd heard January and then I read before I came. When you described it, I was the first time I realized the .15 is a screener. It's not an assessment of what we think water should have in it. It's a screener that kind of like with children, the difference between a developmental screening and a developmental assessment, and the screening tells you go for the assessment. And so that was helpful that was very helpful to me. But do you have any, the second is a question about when the test comes back and it's not the faucet. I think replacing a faucet, we usually have to do that multiple times in the life of a house. It's not a big deal. I have replaced all the pipes in our 100-and-some-year-old house. That is a big deal. So do you have any, from your work in Oregon, do you have any idea of how common it is in residences that the screener will find that it's the pipes in the house?
Versus a faucet.
Yeah, I think the faucet is, it's a problem. If you're a low-income provider, it's a big problem, and so I don't want to be insensitive. But it's not going to be a crisis. Redoing your plumbing is a big deal. All the pipes in the house.
Right.
That's a big deal.
Dave Emmy for the record again. We have some information from the Portland Water Bureau. They, as many of you probably know, they offer free lead testing for any of their customers. And so they have a fair amount of data. And I think just kind of anecdotally, there's factual information we can gather to try to answer your question. But the most common thing, I think, are sources of lead that they find are faucets, sometimes brass valves in plumbing. And yeah, you can get lead leaching from older pipes pre-1986 that use lead-based solder. But even with some of those, they're finding, even in some of those households where they're sampling routinely under the lead and copper rule, they're not finding that high of levels, and it seems to be fixtures more often than not. If it's the plumbing, that's probably a case where you're going to look at, well, I'm going to provide some alternate water supply for my business, or you're going to look at filters, right? That's probably the mitigation.
We have Shauna who wants to get into the queue.
Oh, okay. Shauna on the phone.
Thank you. I just wanted to, I really appreciate what Patrick said regarding regulation and really helping us to understand, as Miriam said, as our advocate said, as Eva and Khalees said, we definitely agree that ideally no lead in the water. That's what's safe, is absolutely zero. And I think it's great that we understand that line between regulation and what we want to have happen. And I think that education and awareness of the early learning division in doing work going forward to make that clear to providers, I think is going to be very beneficial. And I really appreciate this opportunity for us to get a scan of the entire state to get a better understanding of where the concerns are. For me, when Andre mentioned that when they screen children, I believe it was in Portland public schools, that only 2 of the children had levels that were concerning, and they had other exposures. And I think that's an important, we've said we don't have the health data that we would like to have, and so we can't rely on a bigger study that tells us that, but I think that one sample is a good example that there are other exposures we need to worry about, and that the 15 parts per billion is a good level for regulation and a more stringent level than the EPA currently has. Thank you.
Thank you, Shauna. Anybody else on the phone with a question or comment at this point? Okay.
Yes, Kelly.
Oh.
This is Kelly. I do.
Okay.
I am I appreciated the comments as well. I think I'm struck by the fact that the council initially was told that, and I think this is what he's clarifying, we were told that it was, I feel like we were told it was safe, which is what led us to the initial conversation. And now we know that it's not, but I feel like we made our decisions prior based on the information that we had, and now we have new information. But I guess I'm struck by the contrast of that information, and so I'm also really appreciative of being educated on this. I do feel like, I can't speak for everybody, I know that I was under the impression that it was safe as long as it was underneath, this certain level. I am struggling with the fact that there is no safe level, but we have this sort of arbitrary regulation, and I don't know what we can do about it, but it seems like that seems flawed to me. If we unequivocally know that it's not safe, and then there's regulatory things that say this is okay, those don't align with one another. And I think everyone, as Shauna, I think, just articulated, everybody in the council wants to ensure that children are as safe as possible. And so, I don't know, I'm wondering how we can get to a place where we're not having to do a regulation that's above what the ideal is. Does that make sense?
Yes,
yeah.
sure. We'd all like to say one.
Yeah.
I think a couple of things, and Pat, I really appreciate some of your comments. To me,
But others not so much. Huh?
all of them, appreciate them all. The idea that, as I understand it, we are requiring the most stringent tests by having the standing water test. And that's going to be more stringent than the running water after a minute or whatever it is. Are we requiring both of those, that the providers have to do the standing water and then the running water test? So we'll have that comparison for all providers. Is that correct?
Not necessarily. Like I said, the kind of standard practice is to collect both of those samples, but not necessarily analyze them, depending on the result. Because if it's low, below 15 in the standing sample, you wouldn't analyze the other.
Okay, yeah. So everyone will have the standing standard, and then if it's 15 or above, they would get the running water as the secondary.
Yeah, that's normally the sampling protocol, yeah.
And that's the protocol that we're requiring in our rule, correct?
It would be part of that corrective
It's
action.
in the EPA 3Ts guidance.
3Ts, yeah, I
Yeah.
never understood those until recently. I've never heard of those till recently, actually. Okay, so we know that we're going to be gathering data, and one of the piece, Pat, that I wanted to comment on that you mentioned was really relying on the health department with us to gather this data and then be able to report back to the council in 6 months or January, whatever the timing is, and say, okay, to date, this is what we've found. These are the numbers and the percentages that, are above 15 standing, but below 15 when it's running, and all those different iterations, so that we start trying to get our heads around what is the problem, how big is it, and is it in isolated areas? So we'll need to know center-based, home-based geography. So we probably should intend to revisit this in January or whenever we will have enough data so that we could do some assessment of how big a problem is it, and should we be looking at other ways to try to address this.
If I can build on that, Sue, I want to also remind the council that we have requested for this, we have requested resources from the legislature to cover the cost of tests for our regulated subsidy providers, and we have, as part of those conversations with legislators, talked about the fact that we would be using this data to understand what kind of resources are needed to support providers in mitigation. So I think, to your point, Sue, that we have in our conversations with the legislators been pretty clear that, you know, we want to work closely with the Oregon Health Authority, get this kind of data together, and then be able to analyze that together and understand what you know, how extensive is the problem, what kind of mitigation is going to be most effective, and what are the resources required to do that.
Right.
So I think that, you know, to your point, Chair Miller, I think that's a good, probably a suggestion, and being able to come back to the council as well and report on that as we do that work with the Oregon Health Authority. I think.
So what is the timeline on that, Dawn? I can't remember. In the rule, we're saying you have to start testing immediately and have results by September, is it?
30.
September 30. So we would have some data from that by the fall. September, what is that, 5 months?
Data being, data, excuse me, data being data, it's probably safer to say we would have something that would be in a form, we might be able to talk about what we can do with it early in the following year.
Okay, so January, February, sometime in 19. Okay, well, why don't we, council, consider just being really clear with ourselves as well as staff and the public that we know this isn't a, you know, one time and we're done with this issue, that we will be following it and looking for additional information and follow up, so we can continue to consider what's best for children in our state. Bobby, and then
Well, there's just a staffing issue. I mean, data sounds great. Somebody has to be carefully, somebody has to create a database to put it in, somebody has to carefully input the data, and then somebody has to analyze it. So when we say this is a division that's not overly staffed. I'm just a little worried. I mean, we're making it sound like, fine, they'll send us data and we'll have a report, but that's time consuming.
But we're saying that providers have to get this information to the
Yeah,
Office
but I'm
of
talking
Child
about
Care.
what ELD has to do. ELD has to have a system for collecting that data, for inputting it into a database. Don't they have that? Who, okay.
Pat, are you
Oh, maybe
collecting the
OHA
data?
does it. And then I won't worry.
If I may,
Yes.
Bobby, we definitely have thought about that, and by no means do I think this one person isn't, I mean, it is going to be a big lift. But we have a dedicated person that we are hiring for to really do that data entry, that collection, that organization of the test results as they come in. We're also really, you know, seeing how we can get that incorporated into the database, and so we will have a dedicated staff person that's really working on that. And you know, I think once we get
Temporary.
temporary, yes.
Yeah, but
To get us through this is identified to really, because it is going to be a significant amount of work to get the information in, and I think that's why getting help with the corrective action and some tools that we can really lay out will be an intensive training for our licensors as well.
Right. But yeah, I mean, I think that there's some of the capacity around managing the data and information and the communications with providers while we're trying to, you know, support them and kind of implementing this new rule. We do not have the expertise of safe drinking water, and our public health colleagues is who we'll be kind of relying on to help us interpret the data and understand and develop the kind of recommendations and training, and to Pat's point, all of the ways in which the providers will understand the rule, mitigation, the kinds of training that our licensing specialists will need to be able to ensure enforcement of the rule, right?
Yeah, from my standpoint, from a public policy and health standpoint, the data that will be interesting is the data that are the points, the results below 15. And what are they, and what do they mean, and what do they imply for policymaking? Where it'll get real darn exciting for the council are the number of providers that are above 15, 50 or 500, right? Because 50 looks like one thing and 500 looks like another in terms of mitigation plans and and all that sort of work. And that's going to be I would presume, the much more immediate
Absolutely.
concern.
Yeah, and how much retesting is going to be required of providers, sort of all of that. So it is really, in working very closely with OHA and the Early Learning Division to put this rule together is really, I think, a recognition on all of our parts through this collaboration. This is really the first step that we're taking to be able to get this information and start communicating around these issues with providers. But there's a lot more work ahead, I think, together to ensure safety for children and drinking water. And I wanted to come back to, I think, a point that comments that some council members have made. This is going back to the issue of the what children are ingesting. This, as I've understood it, and by far not an expert, so Andre, Dave, correct me if I misspeak here, but an action level of 15 parts per billion has been stated, or even at 10 parts per billion is not indicative of what children are actually drinking and ingesting. It is a first draw sample where you want to see the maximum amount of lead leaching into the water to inform corrective action, and highly unlikely that that is the level that a child would ingest if they were drinking that same water sample. So that is why we want to, as we move towards understanding the need for corrective action and mitigation, it's almost like trying to get the worst case scenario here through the test, and then be able to understand and get the data and be able to guide providers on what the appropriate action level is. So is it accurate, Andre and Dave, as I've understood it, to say correctly, if you're at 15 parts per billion or where you're at 5 parts per billion, the differences in what you're ingesting are that different? Or can you expand on that? I feel like that issue needs to be clarified specifically for the council. I mean, you talked about some data from Portland saying 93% less than, so if you could just expand on that, because I think that's still an area where council members may need more information.
Yeah, Dave Emmy, for the record, I think that pretty much everything you said was accurate.
Well,
Again,
I've been trying to learn a lot from you guys in the last couple.
You're a quick study. Yeah, it. You could set a lower level. You could choose a lower action level, but from our standpoint, the relative risk reduction would really not warrant that. Again, it's a confusing thing because you throw a number out there and you're talking about something like lead in drinking water, and less always sounds like a better thing. But really, I think that this system that EPA devised of just finding and fixing a problem is a good place to start, and there's no reason not to do that. And it will yield some health benefits, I think. Picking a number kind of arbitrarily that's lower, may run into some problems with laboratories being, unable to meet some of those levels, or with, other issues with people, rushing to put in filters, and maybe that leading to some problems as well. But I think our feeling is that, and based on the work we've done, that this approach in the regulations of establishing an action level and also providing guidance on a routine basis to flush the taps, and that those two things taken together is protective.
Of what a child is ingesting.
Right.
Thank you. Thank you, Dave. Council members, are you ready to put a motion on the floor?
Chair Miller, I think I can make the motion, but I'd like to be clear before we make the motion that we are going to revisit this at some point. So how do you want me to address that you want that as a separate motion. And then a comment, I think we're all feeling a little bit stressed by, having to make the decision. And my feeling is something is better than inaction.
Yes.
And I think we need to at least start there and maybe move, but I think we need to revisit this at some point. So Chair Miller, how do you want me to address that?
Well, it seems to me that, one approach, I don't know if it's the best one, is let's pass the rule. And then, I don't know that we need a motion, but we can go back to the conversation we had just a few minutes ago, saying we really want to revisit this in January. Let's see what results are available by then. And then we'll know that it's coming back to a council agenda. We also know mitigation is going to have a cost that goes with it. Some of it is. And so we've already talked about needing to go to the legislature and ask for some money for mitigation. We just have no idea how big or small that is.
Right.
But January will be at the beginning of the session, so it would give us some time to try to do some educated estimate of what do we need to ask for.
So I think you've answered that question. We don't have to.
No, I think staff knows it.
We'll be
back
working on it,
by
and so we will
January.
be, yep.
I mean,
We can certainly keep the council
because I think the
updated.
analysis that Oregon Health Authority can provide is going to be pretty critical. So, Chair Miller, I move that we accept the changes to the regulated subsidy family child care rules as provided
All right,
in
is
our
there
notebooks.
a second for that? Pat seconded it, thank you.
Oh,
I
Yes.
have an amendment.
Bobby,
But I also have a question. This applies to all our rules, doesn't it? Not just regulated subsidy?
Yes.
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 It's registered family, that's a clarification. Registered family, certified family, everybody. All our rules are getting
Yeah.
revised.
So I will take the friendly amendment to all the rules that are in section 1 of our notebooks.
right. And it's not license exempt providers because they aren't licensed.
They're exempt.
So they're exempt. And I think we can do our best to inform them and make sure we've got a really massive education program so they understand for the safety of the children they care for, they're going to want to do some of this, at least the running water.
For more discussion, I just make one point.
Yes.
I have an amendment.
Oh, go ahead. I thought that was your amendment.
A proposed amendment, and then,
Oh.
yeah, okay. If a provider replaces any faucet or fixtures at any time after sampling has been, the facility must notify OCC and sample the water from the faucets and fixtures identified as to be used for consumption, and provide the test results to the OCC within 10 days of receiving the results. So it just adds that if they've changed a faucet or a fixture, that they have to get the testing done again. And within 10 days of getting the results, that they have to send them to OCC.
If I may, I think the rule already, as drafted, says something very similar to that.
This would
in-
be, so right now, it calls that out as a mitigation.
Right.
They have to retest once they've mitigated, so, but if in 3 years you decide to remodel your
Oh,
kitchen.
regardless of mitigation.
Yeah, regardless of mitigation,
Got it,
yeah.
okay.
Would it
Which we
be
can add
helpful
that.
to say, replaces any faucet regardless of mitigation, so that other people don't get confused?
That validates what they've
Yeah.
done. Yeah. Thank you, Bobby.
Chair Miller, the maker of the motion, will take that as a friendly amendment.
Okay, thank you. All right, so the motion then is now, includes the amendment. Any further discussion of the rule? Yes, Donalda.
I just want to point out that I think we've all said that we really think 0 is the best for the safety of the children, but that what we're doing is a progressive event so that we can see where the outliers are, get that addressed, and then we will come back so that we can address the full issue of the safety of the children. sorry.
Yes.
It just feels a little, we're all saying that, but then we're also saying that the level is just to get us started in implementing better practices. But I think our bottom line is we really want to get to the best practice, which is 0 for children.
Right.
I just, because it could be construed that we're okay at this level. We're just using this to get us started and to define what the real issues are out there and find the data.
I think
Just
we're, yeah.
feel like I needed to say that because children, we still have the bottom line is what's best for those children.
The thing that's the most helpful to me, Donalda, is we're not saying any level is okay. What we're saying is that at a certain level, they have to mitigate. And we set that for a screening. So I don't know, that was really helpful to me, that to be very clear, we're not saying that any amount of lead is okay for children. We're saying you have to mitigate at this level.
But that becomes a minimum, and then people tend to say, okay, that if I'm at that level, I'm okay. And we're saying you're not okay if you're at that level. We're going to start there.
Right. I think
That's all.
what I've understood too, just to build on that, Donalda, is that minimum level for action, there is not likely to be a difference if that was at 15 or if that was on 1 on this particular test.
It's that
That's what
dose
I've
duration.
understood. Right. So I think that what we're all though saying is, and again, I'm not the public health person, so I'll look to my colleagues, is what I'm understanding you're saying too is what we're striving for is to have a health-based standard, right, and a procedure, right, that ensures that, which we don't have at this point, but we hope we'll be able to work towards. But I think for me, the understanding that, again, what the real concern is around making children safer in this rule is, are we going to have the kind of action in places where people will have to mitigate if there is a likelihood that they're ingesting lead in water at 15 parts per billion or above? We will. Mitigation will take place, be required. And it is unlikely that below 15 parts per billion, they're drinking water that has been tainted with lead. But again, that's something that, we need to continue to look at with the data and look at with OHA. Am I accurate in that, Dave and Andrew?
Yes.
Yeah, and that'd be considering that you're doing the basic flushing on a regular basis.
And data has been shared, I think, from Portland Water Bureau that is indicative of that. So that is, I think, the space where we are. And so to Bobby's point, we're looking at a screener where above 15 parts per billion is even sort of more conservatively where we are going to trigger mitigation and corrective actions.
We think that will be protective of children, recognizing.
Yes.
That is what our public health colleagues have assured us. So.
Right. Any further discussion? Anybody on the phone, further discussion?
So hearing Donalda, this is Carmen hearing Donalda, and then hearing also Miriam, there's as we're making this motion, the clarity of it is, because I'm hearing two things. I'm hearing as a council, is our belief that no lead should be the goal, and we're going to progressively look at this to be able to accomplish that? Or are we saying that we're going to base it on the current standards and evaluation that our colleagues have set? Therefore, we are okay with certain levels of lead in the water as we're also doing this. So I think that that's the confusion, because I feel like we keep on going around the issue. And so I would love for somebody to make the statement, what is our stance as a council, and then what is it that we are going to be voting for, understanding that we're going to come and reevaluate it, that there's a process. Because still I'm hearing multiple things as different people engage in the conversation. So what's our stance as we're taking this vote, and then what is the vote?
Carmen, if I were to summarize what I think I've heard from every council member who has spoken on this, the stand of the council is that we want no lead ingested by children, period. Now, the rule before us today is a step toward that, but it's saying we need to get some data. We need to find out, what's the universe like in Oregon for children in childcare, and we're using 15 parts per billion as sort of the trigger point for that, which is less than the national standard that the EPA has put out, and it's based on what our Oregon Health Authority is recommending. So that, I think one of you has said that's sort of the beginning point. That's what's going to get us started down this road. In January, we will have some data. We're not sure how much, but we will have some data that can start giving us a sense of how big an issue is this in Oregon, and then we can decide what are our next steps. And hopefully somebody at the national level, I'll say
Just leave it there.
is trying to work towards some kind of health-based standard, right, somewhere. So we're also hoping we can take advantage of that in our lifetimes. So Carmen, does that answer your question? And council, did I summarize sort of where I think every one of us is?
If I might, I could give, I think, something that might be relative to this. When we're looking at mercury in fish, we know that fish have mercury. But we came up with saying, okay, with pregnant women and children, yes, you should still have fish because it's a good thing to eat. But don't eat it 5 days a week. Eat it 3 days a week. I think that's what we're saying here. We're trying to find out what that level is, but we know that at this level, this is still has some, but it's the more minimal amount, kind of like mercury in fish.
Sorry, it appears that the phone disconnected, so
Oh.
I was
What happened?
They can't hear us on the phone anymore, so you have to dial back in.
All of them?
No, yeah, but it just happened like 30 seconds ago, so they've been here for most of
Yeah, they missed the whole thing.
Yeah.
I have to start over.
You can make your comments.
Start over at 2:00.
We'll just play the tape.
Dave, Andre, could I ask a question again about the, just going back to some of the education that we have to do for providers? And again, I think getting at that real question of how will a provider know through the test process if they, their family, the children in their care have levels, there is any presence of lead in the water that they're ingesting. Am I correct? I think this would be helpful for the council, but would we be, or should we be pointing to that the second part of the test, so the test after the flushing, and giving guidance? I mean, that would be is it accurate to say that would be the level where you wouldn't want to see any presence of lead?
Yeah, Alyssa had said still can't hear, so she's trying to fix it, and she knows that
We hear you.
Now we can hear you.
Back on.
Can you guys hear us now?
Okay, good.
Okay. Does my question make sense? I mean, that's the running, I'm back to the running water sample.
Yeah, again, it's probably more representative of exposure throughout the day, is all I would say on that, yeah.
Okay.
Yeah.
And so you would want to see that at zero, irrespective of,
Yeah, ideally,
okay.
you would want it to be zero. I think, in Portland, and Portland's not always a great example because of their uniqueness with their water system. But anyway, I think looking at some of their data over the last couple of years, about 56 or 60% roughly of the samples that they collected at customers' requests we're below a part per billion. So, you know, that gives you some gauge.
In the running or in the standing?
In the, I believe the standing samples.
Standing, okay.
Yeah.
Okay.
All right, you ready to vote? We've got other stuff we need to do. Bobby?
I just want to be sure that the education campaign covers paint. It's the bigger danger, and so I don't want us to lose the real point of all this, which is protecting children. So I hope that anything we do is lead, paint, and water. Thank you.
Okay, thank you, Bobby. All right, let's go ahead and vote then, council. Those in favor of approving this rule, knowing that we'll get more information in January, please say aye.
Aye.
Aye. Any opposed to this motion? And any abstentions? All right, the motion passes, so the rule goes into effect, and we will you keep us informed, Dawn, sort of as your education program rolls out? And obviously, there's a high level of interest among lots of us. So if you could just let us know how that rolls out, that would be great.
Absolutely.
Thank you. Andre and Dave, thank you very much for your continuing partnership.
Thank you.
We'll look forward to seeing you again in January. You can put us on your calendars. And Pat, thank you for your help in guiding this as well. Let's move on, council, to our agenda, and next is the director's report. So Miriam.
Great, thank you, Sue. So just a few updates. One, I'll start with sharing that the Early Learning Division is moving over to the VETS building. So we've got the Office of Child Care moving beginning this weekend, and we'll report to their new location on Monday. And then our team, myself included, over at State Lands Building will be moving Friday, March 2nd, and we'll be reporting to our new location in the VETS building on March 5th. So,
wow.
Yeah. The VETS building.
Veterans?
We're moving basically across the street.
Okay.
I keep joking with Dr. Richardson that I'm just trying to move closer to DHS. So he likes that, but very exciting. It's a great, as you can imagine, a lot going on with trying to move offices. And then Alyssa, I think the good news for the council in our new location is that we'll be able to have our meetings there.
We're going to have our own meeting space with technology that works, cross our fingers. So we'll have the same location consistently, so that'll be a great setup for us.
Awesome. And, I'm very excited about having the Office of Child Care co-located with the rest of the division. Having those separated all this time has just made no sense. So I think that is a very exciting part of this as well.
Exactly, and the team is very excited too to all be in one place. And there's some really great, I think, spirit and traditions that the Office of Child Care has. I've caught on. I think they're a little more fun over there around different events than we are at ELD. So I'm hoping that rubs onto us. So very exciting. And yes, I'll be closer to Kim and Dr. Richardson, so that'll be fun too.
Watch out.
The second thing I wanted to say, just relative to kind of administration updates, is again, just revisiting Vista Logic, which I've been reporting on. So the contract and statement of work are currently sitting with the Department of Justice for review. So I've asked Ben to give me a very conservative deadline. By when do we think we will have this contract signed? And he said the end of March, thinking very conservatively, hopefully before. So
Chair Miller, can I?
I was waiting.
2018, Martha.
So,
The home visiting?
yeah,
Finally?
that's what it is. So Miriam, I appreciate that you've asked Ben to do that because we had quite a conversation at our last Best Beginnings meeting. And it's by June of this year, it will be 3 years that HFO will not have had a database. And it is putting them in a very precarious situation. I think the council needs to know. We're out of compliance on HFA standards. That was part of the review. And it concerns me that we don't have adequate data over the last 3 years. Makes it very hard for us to look at a program and say this is our flagship star statewide program without the data. I know that it is not the Early Learning Division's fault, but I do believe that some of our partner agencies have not found it to be critical, and for us it is. So again, thank you for asking Ben to make this a priority. Donalda will tell you, I'm just at a total loss.
Thank you, Martha. We will keep on it, and hopefully we'll have good news to report by the next time that we're together, that we're moving forward. The last thing I want to touch on it with respect to administrative updates is that we are recruiting for an infant and toddler professional development specialist that will be joining the Quality Improvement Professional Development team within the Early Learning Division Office of Child Care. So, John, that position is posted right on our website right now? No?
Not yet. I think by the end of this week or first part of next week.
Okay,
it should be
okay. So if you know of individuals, we're obviously looking to recruit somebody fantastic that can really help bring the perspective of practice with infants and toddlers specifically to our work around professional development content, training through Spark, through Oro. So it's really exciting to be able to be in a position to add that kind of expertise to the team. Yep. I think we could circulate, Alyssa, could we circulate the position announcement when it's posted to the council so you can assist us in our efforts?
Great idea.
Okay, and please, share with your networks, colleagues,
Right. Everyone will say, just don't take my staff.
Right. Donalda's like, oh no. Because we are moving and we are so fun to play. It's such a fun place to work. The second update I wanted to provide is with respect to the Oregon Pre-Kindergarten Program, so OPK. We have some OPK funding resources that we are going to be making available to our partners, current OPK providers, to be able to do a pilot of extended day pre-K under OPK. So we're calling this the extended duration pilot. And this is, I think, a very exciting position for us because we know that through our work with Oregon pre-K providers and Head Start providers, through their community needs assessment, we're increasingly identifying families for which they would like their child to participate in full day pre-K as opposed to half day. So we're seeing that through the needs assessment. There's also some research as we know about the benefits, particularly for children in poverty or in low-income families, of full day pre-K over half-day programs, as well as we, as you know, with our Oregon Pre-Kindergarten Program, we follow the performance standards and the national best practice standards of the Head Start program. And so the Head Start performance standards have been shifting and moving towards extending the Head Start day, they refer to it as duration. So, for all of those reasons, we think it's important step to be able to work with our partners and pilot, extending OPK to full day. We expect to learn. It will not be a significant amount of slots. So we expect probably to make to be able to award full day slots for somewhere between 100 to 140 children. But I think what is going to be really important is as we work with those programs that are awarded this and participated in the extended duration pilot, we're going to learn from them about, you know, what resources are needed, what kind of capacity, organizational capacity and support is required in order to be able to support programs in transitioning to full day, if that's something that it makes sense for the families that they're serving, and is demonstrated as a community need for them.
What's the funding source for that?
These are OPK dollars.
Oh,
Yeah.
okay.
And it's full day till 2:30, or?
We're following the guidelines. Great question, Bobby. We're following kind of the federal guidelines. So they're looking at, it's a certain number of hours over a period of 8 months. So the programs still have the flexibility to set those hours.
And some programs have found 6 hours, some found 7.5. It depends upon the community, it seems like.
Absolutely. So
It's OPK, not Head Start.
right, it's Oregon Pre-K, which follows the Head Start performance standards. So we're looking at a timeline of a mid-March release, guidance for the application, April to review final selection, and then make decisions and be in negotiations on budget with the selected programs in May. We do want to be able to provide programs a startup period, sort of with some initial funding, and then would hope that they would begin providing under the pilot full-day services beginning in September.
Eva has a question.
Okay.
All right, Eva.
Thanks. So I think that's really some good news. And then, of course, my question is always around, do we also have wraparound supports for those families, for those who work longer than the 6 hours or 7 hours that the program is open?
I wonder if she's on a speakerphone.
This is Shauna. Can I speak to that?
Oh, sure, Shauna. I didn't quite hear Eva's, okay.
Oh, her
The
question.
wraparound services.
Okay, go ahead.
Eva's question was about wraparound services, so
Okay.
people that need more than the 6 hours, was what she was asking about.
Okay.
And currently with the programs, because there was a federal funds released to do duration, so a number of our programs have a small number of slots that are doing it currently. And by and large, the families that are utilizing those extended hours are different than the kids that have the contracted slots that actually have like full day wraparound services. So we still have the full day wraparound. At this point in time, it's a very small pool that is going to be doing the pilots with the extended day. And so at this point in time, they haven't joined, but at some point in time, as there are more slots that are extended day, I'm sure they will merge.
Awesome, thank you.
Okay, any other questions on that? Okay.
Okay, great,
Miriam?
thanks. So next I'll talk about a legislative update, so share some information, with regard to activities with the legislature during the session. So first I want to talk about HB 4065, which is our child care safety bill. On Thursday, it passed out of Joint Ways and Means Education Subcommittee, and it was amended in the committee to redirect civil penalty funds received by the Office of Child Care to the general fund. So under existing law, civil penalties are currently deposited in the child care fund. So that was the major change. We've been working.
Can you repeat that? So they took the money that we were going to have as penalty, that we already get as penalty.
Yes.
And put it in the general fund.
They're going to put it in the general
So
fund.
how are they going to fund?
Of course, Lisa Pinero just walked out of there. No, but I think here's Dawn. Why don't you come back up and help on this part? But as I'm understanding, we are a bit of a I should say this is only around civil penalty funds. This isn't about, it doesn't affect fees or any other things that we collect. We are a bit of an outlier with regard to other state agencies that receive their civil penalty funds from civil penalties directly. And in our work with the legislature and the Legislative Fiscal Office to sort of analyze, to understand the implications of this change. I think we're understanding the impact could be under our current civil penalty structure about $10,000 to $20,000 a biennium, and we'll be working to sort of backfill that through general fund. So, Don, anything you want to
No,
add?
I think that's exactly right. And so while they're moving it to make it more consistent with how other civil penalties come in, that there, will be an adjustment on the general fund side to make it not a loss of funds.
Right.
This is David.
Thanks, David.
I'm not sure if I can be...
Nope, jump in.
Sorry to jump in. The only context I wanted to add is there, I think, is a standard concern from both the LFO and legislature of not wanting to create any incentive for an agency to have for imposing penalties, right? So they didn't. So I think the concern was if the funds go back to the agency, then the agency has an implicit incentive to impose penalties. So I think that was really what the discussion was about.
Okay, thanks, David.
Thanks, but otherwise, really good news. It's on its way to full Ways and Means Committee and then to the respective chambers for a floor vote. So very exciting.
And when you say the child care safety bill, this is the one
with the enforcement, greater
The
enforcement.
staffing.
Yeah. No. Go to staffing next. That's the greater enforcement tools.
Okay.
The work of the statutory working group.
Right, which are it's mostly a policy bill.
That's right. Yeah.
Okay.
Yes. So next I'll talk about the staffing, our agency staffing requests. So myself, Dr. Richardson from the Department of Human Services, and Dawn testified before Ways and Means Education Subcommittee on Tuesday, February 13th. And so as you know, as a reminder, this request includes is a request for additional staffing for the Office of Child Care Licensing Program. It would provide resources for conducting tandem investigations with Department of Human Services, CPS, in investigating allegations of child abuse and neglect at child care facilities, and it includes the resources for the lead testing of drinking water for our license-exempt providers. We have been working really in close coordination with the governor's office, as well as they've been having conversations about the governor's request during the session. I think continue to get really great feedback from legislators about the importance of this and their support of child safety and the council's actions around lead testing, as well as the strengthening of our licensing program and what we're trying to accomplish there, including the collaboration with DHS. So we know it sounds like Martha could probably share more about this too, but looking like they're going to be wrapping up very soon, so we'll know. But so far, I think we've gotten really good feedback.
So do we know when it's on their agenda to send it to Ways and Means, pass it and send it to Ways and Means?
No, I don't have that information. David, do you have any sense of next steps?
I don't have any specific information. My sense is that sort of all of these pieces all of the revenue requests will move basically at the same time when they have a sort of full sense of what they're working with.
Right, so next week.
Right. Yeah, it's almost time.
That's all there is.
The deadlines are for, right?
Right,
To take
absolutely.
action. Okay.
Okay, so in the interest of time, I'm going to kind of try to move forward really quickly. I want to share sort of next item is related to an opportunity that the Early Learning Division has been, an opportunity that we have to partner with the J.B. Pritzker Foundation. So they are a national early childhood foundation that has launched a new Prenatal to 3 initiative. And this effort is to support states. Really what the foundation is seeking to do is create a couple of model states that are really demonstrating strong prenatal to age 3 systems, particularly looking at, and looking at this from a very much a cross-sector perspective, which is fantastic. So the foundation has really 3 main priorities associated with this initiative. One is what they call Universal Connect. So this is looking at systems that provide free, voluntary, universal prenatal or newborn home visit available to all families, and as part of this initial home visit, an assessment of support and immediate needs is conducted, as well as connections are made to medical, family support, or other early care and education programs. The second priority for this initiative for the foundation is high quality home visiting, and so they're looking again at states that are, building systems that allow for more families to be able to access evidence-based and high-quality home visiting programs, again, including programs that support linkages to other comprehensive services. And then the third priority is around high-quality childcare. So they're looking, again, at states' activities and efforts to build systems that support infant and toddler teachers, caregivers, create hubs of support for family childcare and family friend and neighbor providers. So as you can imagine, this is very aligned, I think, with a lot of the conversations we've been having. I want to acknowledge that Director Allen participated in a site visit when the foundation was visiting Oregon and meeting with a number of stakeholders, and it was so impressive that they have invited us to apply.
Mostly I introduced Kate Wilcox.
Yes, that's right.
Impressed
That's right.
them.
And impressed them a great deal. But I think this is really, to be invited to apply, this isn't an opportunity that's being afforded to many states at all. I think they're really starting small with just a few states that they want to be working with. I think really speaks to a lot of what the council has led up to this date, great cross-sector partnerships, the fact that we had a council, the fact that we've got really great external partners and stakeholders that share, I think, the vision that we have around and prioritize prenatal to age 3, sort of all of those things together, I think made them really feel like Oregon was a great state to work with. What this will mean is that for the Early Learning Division, we will be given some resources towards supporting a prenatal to age 3 policy fellow that will be in the division. And we will also have access to technical assistance. And so the idea is that this policy fellow will be dedicated to prenatal to age 3 kind of systems building work, be able to work really closely along these 3 priority areas with our colleagues in health, as well as human services, and that will be benefiting all of the agencies from the technical assistance that will be provided. It also allows us to be part of this, will be connected with the other states that the foundation has selected. So there will be some opportunity for information sharing and exchange of learning across the other states.
So being selected to apply, does that mean we are selected?
Pretty much, yeah.
Okay, thank you.
Yeah, they're not inviting you to apply. So they did the sort of front kind of scan by the site visits and all of that.
Okay, thank you.
Sure.
So what would be the timing, Miriam?
We have to submit the application. That's a great question. We have to submit the application by the end of March. And I think they are, it's my understanding, looking to have a convening of their states together in June. So I think we're moving on a pretty fast timeline. They've also, so that is, I'm really speaking to that capacity that they're building within state government to focus on prenatal to 3 systems work. They're also going to be making investments with external partners. We have learned from the foundation that they have identified Family Forward, Ready Nation, and Children Institute and Children's First as their partners as well, that they'll also be working with around building capacity to support prenatal to 3 systems work. And as part of this application, they are asking their the external partners and the state agency to collaborate on a joint statement that will talk about the way we'll be coordinated in our efforts.
Family Forward, Children's Institute, and who's the third?
Children's First.
Oh, thank you.
And Martha.
Oh, 4 then.
Yeah, 4. So, David or Martha, anything you want to add?
I'll just add that we're really excited, or at least I am on my end. Pritzker's pretty big, and coming into the field of prenatal to age 3 gets pretty exciting. So I can't wait. Our work is probably going to be backdated a little bit from Family Forward, Children First, and Children's Institute, because my funding is going to come through the national grant, and theirs will come through a state grant. Yours will be separate, or Early Learning Division will be a separate grant. I can't wait.
Very exciting.
Yeah, it really is.
And the council's talked about really trying to make sure we have a focus on that prenatal 3.
Yeah.
So this obviously aligns great with that.
Absolutely. And I think that's a good segue into the final update I wanted to share, which is about
I just want to say one other thing. I think we all need to be very aware of the fact that I would wager a major reason Pritzker has looked at us is because Miriam is our director, and she has had previous experience with and built relationships with them for several years. So I think it's just another piece. Obviously, Oregon needs to, as a system builder, et cetera, it needs to warrant the grant. But I think we really have you to thank, Miriam, for having them look seriously at including us. So thank you.
I think that what I wanted to sort of last point and segue is Children's Cabinet and provide an update on that. But as Lindsay and I have shared it at a prior meeting, the governor's convening this cabinet, and Director Allen and I have the opportunity to sit on that cabinet along with the Director of Housing, Human Services, and Colt Gill, our Deputy Superintendent, as well as a number of policy advisors in the Governor's office. And so this is, I think, a great opportunity where we can connect with, these kinds of resources and align our strategies. We're really not going to be able to move a prenatal to age 3 sort of strategy, particularly one as comprehensive as the foundation envisions, without working really closely with both health and human services. And so I think that I look forward to using, I think, that cabinet and that table, as well as really being able to sort of drive the work internally that we know, and the alignment that needs to happen in state government, within state government, to support this agenda. And I think the only other piece I want to say about the Children's Cabinet is to share the wonderful news that our chair, Sue Miller, will be joining the Children's Cabinet, which is exciting. And I think that is really timely, because one of the things that we've been able to do in working with the governor's office and envisioning kind of the work and the focus for the Children's Cabinet is really align it well to the strategic planning process that is underway. As we know, we're putting together a cross-sector plan really focused on 3 very big, broad, big goals. And so to have both Sue and the Children's Cabinet will be another way in which the feedback and conversations around the alignment work will be brought back to the Early Learning Council, in addition to Lindsay and I doing that as well, where we have had one meeting and are moving toward the other meeting. And one of the things that has happened which is, I think, also great, is that the schedule for the Children's Cabinet is aligning, and the agendas are aligning with the Early Learning Council strategic planning process. So in advance of a sector, cross-sector, a sector engagement session here, we'll have some prep at the Cabinet as well as debrief, so that feedback can come back to the Council. So it's all very, very wonderful.
If I could just comment
Yeah.
as well. The governor convened that meeting, facilitated it herself, was there
Yes.
for the entire 90 minutes. If you're around government stuff, that's utterly unheard of.
Yeah.
That really draws a big, bright box around how important
That's right.
she thinks this work is. And it's really a big deal that Deputy Chief of Staff is working to make sure this is all lined up exactly with the council's strategic planning process. It's a big deal.
And tagging on to that, Pat, when I was invited to join the council, they told me the dates have been set around the governor's calendar because she intends to be at every one of the cabinet meetings. So it's what you're saying. She's making a real
Yes.
commitment to this. That's 90 minutes. Yeah.
So that's all for me.
Nothing to do. Any questions of Miriam and what she does on weekends or her spare time? I know she works on weekends.
Yeah.
Thank you, Miriam. Thanks for all you do and the many hours you commit to this work. I appreciate it. Let's move on to the committee, the chair's report, which basically is looking at the committee reports that are in our packets. I don't know if, Martha, you have anything to add? We just got these, obviously, so we haven't had time to look at them, but I appreciate that they provide a lot of information.
So, Chair Miller, I do have a couple of things that have happened in the last 24, 48 hours since I did the minutes. We knew a while ago that there was a potential new partnership with the Alliance for Advancement of Infant Mental Health and Healthy Families America. And that email actually came to me when I was on my way down, that partnership now exists. So the long and short of some of the conversation that we had at Best Beginnings about professional development and trying to support our staff and our providers in taking that infant mental health assessment and getting the endorsement is now a level up, because HFA's most likely going to require that for their home visitors and staff. So I'm really excited about that, and Sherry Alderman will be as well, because she's president of Oregon Infant Mental Health here, and is helping us with some of those alignments that we'll be giving recommendations on. The second thing is that the infant toddler assessment that's been going on, they've polled the parents, and I can't remember, I think they had 500 or 600 parents that responded. They're now polling providers as well as Best Beginnings. If anybody on the council wants to also take that poll, I can forward the information, and it closes, I think, the 5th or 6th of March. So we'll be really excited to get that information, because it will feed back into an awful lot of what we do. And then I'm looking forward to working with, or Best Beginnings is, Miriam, your new prenatal to age 3 person that you're hiring under child care, because I think there's a lot of crossover. We're looking forward to that. One other quick thing is that Erin Dean on HFO, our director there, is getting her Coffee Creek home visiting program up and running. We should have parents, or moms, I should say, here in about the next 30 to 60 days. And we also know that not in conjunction, but running alongside of that, is that Multnomah County is doing a similar type project with Inverness Jail. and it's an interesting process. There are some questions they can't ask, so they're having to step around, how do we get the information that we really need? And that's because they're in jail and there are some questions you just can't ask. So, you know, some of the abuse and stuff. So they're trying to process how they can ask some of these questions without asking those questions. So I thought that was an interesting bit of information that came out of Elizabeth Carroll out of Multnomah County. So
And let me just say, you know, on Coffee Creek as well as the Multnomah County one, it's a great example of, once again, another piece of the system, you know, is corrections. And we haven't talked about that a lot. They aren't on the council, so that hasn't been a focal point. But as we all know, it's a very, very important piece of this wraparound for parents, and parents we need to serve.
They do, and Donald wants to say something, but I'll give Erin Dean almost 99.9% of the credit on this. I mean, there's a little bit of credit, obviously, that goes to the corrections department for saying yes, but she found a need. We had a conversation. She came back to me very disappointed, and I kind of forgot about it, and she just kept working at it. Her husband, I believe, used to work there. I don't think he still does. So she saw a need when they had a parent that came out and needed supports, and she connected her through HFO over into Deschutes County and got her thought process going. And she's really the reason that we're going to be doing this project. She's tagged into some other areas that have started, and she's getting information. Start small, don't go big. You know, learn your lessons on a small basis and then work the program up. Washington County's HFO program is the support for that.
Very exciting. We'll start with moms, but we're going to need to get to dads at some point.
Well, the home visiting component too, that emphasis that we have, when you mentioned corrections used to have the largest home visiting program, like 20,000, because of all the probation. And so when you look at many of our women and many of the families, it is an area that we should be looking at, because they're already making those visits. How can we assist them to be supportive of the families, not just the corrections plan, whatever that is. I don't know what those are.
Right, excellent point, Donalda.
We have Eva in the queue.
Okay, Eva?
Hi, can you hear me okay?
Yes, the louder the better. It sounds like you're in a tunnel
In
somewhere.
a phone booth. Are you in the bottom of the Capitol in a phone booth, Eva?
No, happily I'm not. No, I wanted to add, I appreciate this conversation, and I wanted to add that just a little bit of information about another program that's happening. It's the Parent-Child Representation Program that's through the Oregon Public Defense Services. It's currently in a pilot project in 3 counties, and I'm going to mess up which counties. I know Yamhill, Columbia, and I think Lynn, and they're looking to expand it. Essentially what happens is that if a family is in the judicial system, they not only get a public defender if they qualify, they also get a social worker that is their advocate. And the families that have participated in these programs are in the foster system shorter amount of time than those families who are not. So I think it would be nice to have Amy Miller from the Office of Public Defense Services come and present on that as well.
Okay, thanks, Eva. Alyssa's making notes. Any other comments? Or Martha, do you have anything else?
No,
You're done.
I'm done.
Okay,
Thank you.
thank you.
Except our next meeting is the 15th of March. We're having a back-to-back meeting, and we usually go every other month.
Okay, thank you. Thanks for your leadership on that, Martha. Spark, Donalda, we have 2 months of Spark notes in here.
Right. Essentially, we're plotting ahead. And really, because there are several different groups working on Spark, really identifying that policy role for the Spark ad hoc committee. We're also still recruiting for a couple more members because I think we lost 4. We just haven't been successful in getting some representation from some of the other groups in the community. And we really want to get some representation from communities of color to be sure that we are representing their needs as well. The good thing is we'll be coming to you shortly, sounds like an advertisement, in April probably with the policy. We've redone our timeline and looking at that, and we anticipate that we'll be rolling out the new ones in the summer. We don't have exactly the right month because we want to give ourselves a little bit of time. I looked at Dawn. First somebody said June, and we said, summer, let's say summer. So I think that's the exciting news. And this last meeting, we worked on the transition because we're going to have individuals that are currently in the system, and how do we transition them, and then also new individuals, and helping the individuals that are transitioning knowing what their options are to stay the course, or is there something they might want to take advantage of the new system that we put in place. So I think I looked at Dawn, I think that's most of it. And again, I compliment the committee because we get such rich discussions that I think they allow us to be sure that we're covering all the bases, not only from infants and toddlers, but up into school age.
Awesome. Thank you, Donalda, and for your leadership on that. The Equity Implementation Committee just met 2 days ago, I think. So the notes aren't in here, but we had an hour-long presentation from Meredith, right? Thank you, on Spark. So, and you'll see in the notes from that meeting, there was, I think, some good input to feed back into your committee. One of the pieces of information that I brought to the Equity Implementation Committee was just a reminder, and I think it's good for the council to remember that we have lost 20 quality improvement specialist positions with Race to the Top going away. So as we look at how are we going to support the professional development of child care providers as we roll out Spark, we need to be really aware of the fact that we are understaffed and have had a big hit by losing Race to the Top. And another data point for the council to be aware of is that from 2016 to 2017, there was a 70% decrease in programs enrolling in Spark. Now, staff, Meredith said that's to be expected because when you first start rolling out QRIS, there's a big push and a big recruitment to get providers to get into the system. So you expect to see that taper off. But they're also supposing that some of the connection is losing all of those quality improvement specialists who can work with the providers. So just again, we talk about resources and capacity, but I think those are pieces that we just need to be really aware of as Miriam tries to do the great work that needs to happen. Then last but not least is under tab 3 in our notebooks, the proposed committee roles in our strategic planning process. And we've seen, I think we've all seen drafts of these in the past, and you'll see there's a big draft on this document as well. And it's really important when you look at these proposed roles that you remember it's focused on strategic planning, not their roles in general or for the next decade. It's really between now and probably the fall or the end of the year when we're going to be looking to your committees, council members, to help guide the strategic planning process. And you've got experts sitting on these 4 standing committees, so we just really want to be able to draw on their expertise and people who are already familiar with a lot of our work. So I know the committee chairs have seen these proposed roles before today, and just want to see if anybody has any questions or additional ideas as far as how to make sure the committees are feeding in to our strategic planning process. And the charges are basically what they've been charged with. So the sort of additional information is the committee role in strategic planning. Any additional thoughts, questions? If you, and I know this is new data information for a lot of council members, so if you do have other suggestions, please connect with Alyssa. She's really driving our strategic planning process. I know she was very disappointed to have to cancel our morning because that means she has to reschedule those 16 presenters. And Alyssa, we appreciate you taking the leadership in this and being willing to do that. So thank you.
And I'm happy to resend you a copy of this to share with your committees. I've spoken with Best Beginnings and with Equity Implementation Committee, but I'll send this to you in case any committee members have feedback. Really, this is more of like a planning document so that as we work with Build, we can make sure that we've got our timelines lined up and can engage with all the committees in the most useful way. So it's really more of like a piece for us to work from, and I think that we'll kind of fine tune what it really looks like once we start getting the ball rolling. Yeah.
Okay. I just had a comment, but we should, do you want to pass the, are we good with
Yeah,
the
I think
update?
we're good.
Okay.
I don't think we need to officially adopt this, but just get any input or ideas to Alyssa.
Okay, great.
And it looks great. Thanks, Alyssa. Yes.
I know we're trying to wrap up. I just wanted to mention that the Institute of Medicine, National Academies of Sciences released a really important report, a consensus study in our field around transforming the financing of early care and education. So we will send out the link. So the recording, there was a webinar this morning highlighting kind of the major findings and recommendations from the report. I think the report is, I don't know, maybe 300 or 400 pages. So maybe watch the webinar for the highlights. But just in the mindset of strategic planning, I think it's got a lot of really important information for us. And then there are also 2 other bills in this session that I think we are tracking. One is around aligning special ed eligibility with so that there's a more seamless transition from pre-K and an IFSP to kindergarten. So that bill it has an effective date of July 1st, 2019, but it is moving to the Senate with a recommendation of passage. And then the equity bill, the equity fund, and that is, a fund that's going to support culturally specific early learning programs and parent support programs and services. And so, as I understand it, the efforts on that bill are to get a public hearing in the Education Subcommittee. So important things to also be mindful of.
Okay.
All right.
Thanks, Miriam.
Thanks.
Anyone wanting to speak to us? Anything, other business from council members here or on the phone? All right, if not, we are adjourned.